Hi everyone, our group will be presenting on the environment of practice of the NICU. The NICU, also known as the Neonatal Intensive Care Unit, is a specialized area that certain hospitals have for newborns needing intensive medical care after birth. There are 4 different levels of NICUs classified by the amount of care they provide. Level 1s provide basic care for full-term babies or stabilizing care for ones born near term. Level 2s provide more advanced care for babies born at or after 32 weeks in need of more complex medical management, such as intravenous feedings or supplemental oxygen. Level 3 NICUs, such as Jefferson at Nemours, provide specialized care for babies born before 32 weeks or babies born at any time with critical illnesses. Finally, Level 4s provide the highest and most acute level of care and have a full range of healthcare providers, specialists, and medical equipment. The NICU falls on the acute secondary care along the continuum due to hospitals being acute care and secondary including labor and delivery and intensive care services. NICU services can be delivered through 2 different approaches depending on the hospital. A multidisciplinary or interdisciplinary approach divides responsibilities and duties up based on the professions and specialties that are on the team. In this service delivery model, for example, an OT and PT would have different roles and job responsibilities. On the contrary, some NICUs utilize a transdisciplinary approach in which all members of the team provide the same care and it is more based on availability and scheduling. Through interviewing Dr. Rowan, a Jefferson NICU OT, we learned that this is the service delivery approach used by them. NICU services are marketed through the increasing amount of premature births and rising number of chronic diseases today. The demand for high-quality care for newborns is also increasing, driving the market for the NICU up. The importance of NICU services should be communicated to hospitals by professionals experienced with this type of care.
In 2018, AOTA released a statement describing the role of OT in the NICU, with the goal of providing clear guidance of OT scope and practice. The specific role OTs take on the NICU can vary based on setting and who else is a part of the care team. OT practice with infants is noted that it is very high risk, specialized, and appropriate only for the OTs with advanced knowledge and skills in neonatal care. Because of this, interventions in the NICU context is not supported by those who are occupational therapy assistants, because oftentimes the knowledge and skills are beyond OTA's scope of practice. At Jefferson's NICU, Nemours Pediatric provides neonatology staff, and Jefferson provides nursing, therapy, and support staff. Jefferson is not traditionally a pediatric facility, but because they provide obstetric care, they have a corresponding Level 3 NICU. The neonatal therapy team consists of a pediatric supervisor, who's a speech therapist, and a PT and OT. At this level, OT and PT are very similar, so it can be hard to distinguish between the 2 professionals. Oftentimes, they have to share job duties. They do not see the babies every day, sometimes 1 to 3 or 3 to 5 times per week, depending on the severity of the case. Between OT and PT, they attempt to meet their frequency standards. They provide developmentally supportive care, working very closely with nursing to mimic the environment of a uterus. There's only one OT, as noted, because having a COTA or OT aid is not necessarily appropriate for the setting. Speech therapists perform any feeding evaluations and interventions. At Jefferson's NICU, OTs work on oral motor stimulation and things that are supportive of feeding, but not actually directly involved in the feeding process. Productivity standards in NICUs can vary. At Jefferson's NICU, the productivity standards are from 60 to 70%. As our NICU OT mentions, this is one of the tricky parts of being in the NICU, that in an ideal world, she would come in and bounce around between one baby to another, not worrying about her availability, only the babies and when they're ready for therapy. There are NICUs where therapists are just in the unit and they're not billing for units, but there to work with the infants or nursing staff as needed. But at Jefferson's NICU, they do have these standards which vary based on the baby's care times and the amount of education for nursing residents and families.
Today, I will be addressing supervision and communication framework within the NICU. In the NICU, there is a pediatric supervisor which oversees the OT, PT, and SLPs. This at Jefferson is specifically an SLP. In a 2013 article by Barbosa, it noted that all of the therapists in the NICU typically work together and treat as an interprofessional team. Dr. Rowan noted that this is also similar within her NICU. and that supervision is managerial rather than having an outside professional come in and to conduct treatment observation to meet competency standards. That is all done in-house through scheduling, education, and observation. And most of the communication throughout the unit is done via email. However, there is that slight overlap when shifts change that a PT and OT can relay crucial information for the shift coming in or the shift leaving. Also, they have monthly team meetings where they're able to discuss important announcements and other crucial information to the unit. Additionally, Dr. Rowan noted that mentorship is very important within the NICU and that getting established can be pretty difficult. I will discuss this a little bit further as well. From interviewing Dr. Rowan, we were able to gather her perspectives and perceived challenges of the service delivery area. She works as an OT in the Jefferson NICU and noted that PT and OT are very similar within the NICU. It is hard to differentiate, and thus they work together a lot of the times. And there are always pros and cons to each setting, and one of the biggest cons to the NICU is that the parents do have 24-hour visitation, but they cannot sleep bedside with the babies. She noted that this does cause some frustration and sleep deprivation within the new parents who want to be by their baby's bedside but cannot sleep there. However, one of the biggest pros and most rewarding aspects is that it is family-centered care and that she works very closely with the parents and the infants to work on family goals and different intervention strategies. Also, you work very closely with the parents and families, but additionally work very closely with your other team members, the nurses, PTs, and SLPs. This allows all the professions to understand each other's point of views and really take seriously what each have to say. She noted that OT is valued and their point of view is very valued within her NICU. However, there are always challenges, and a few of the challenges noted, the first being scheduling. The baby's availability is not always regular or ideal. She could be unavailable when the baby is available or vice versa, which causes some difficulties occasionally. Additionally, like I mentioned earlier, becoming established within the setting can take time. Mentorship is a crucial part to this and helps new grads and new therapists within the NICU become acquainted with it and really to get the information and knowledge from experienced therapists within the NICU. She noted that some nurses or other experienced therapy staff will be unsure and a little nervous to have you work alone with infants because of how delicate and crucial their health conditions are. However, working together is always a big part within the NICU. Additionally, another challenge could be that interventions which OTs may want to do, they could not do because the baby is either unstable or physically unable in their condition. This leads to a lot of waiting and waiting for stable patients and different conditions to change in order to do the treatments, and a lot of adapting to the baby's current condition and being creative where you can.
All right, so now we're going to switch gears a bit and talk about funding and reimbursement. So in the US, healthcare is funded through private and public payers, including public programs like Medicaid or Medicare, private health insurance plans such as through someone's employer, or patients' direct payments. There are 5 types of payment contracts that can be used, and those are listed below. If someone is going through a public program such as Medicaid, those are typically financed by the government, but the services are provided mainly through private providers. So some more information on Medicaid. This can provide coverage for low-income families, and then there's also another option called the State Children's Health Insurance Program, which provides insurance coverage for children in low to moderate income families who don't qualify for Medicaid, but also can't afford private insurance. It's important to note that in terms of insurance and reimbursement, coverage for parents does not automatically carry over for children. There's also a difference between employer-sponsored plans and personal plans. So for an employer-sponsored plans, you typically have to enroll the newborn child within 30 days of birth in order to have the coverage carry over. And for a personal plan, the coverage is usually effective immediately following birth. Having a child counts as a qualifying life event, and that triggers a special enrollment period during which you have 60 days from the child's birth to apply for a plan and guarantee your application is approved. And this will allow you to have retroactive coverage to your child's birthday. This is important because out-of-pocket costs can be pretty astronomical, and we'll discuss the details of that a bit later. There are also a couple policies that affect insurance coverage. One of those is the ARIN Act, which states that newborn babies are automatically enrolled under the mother's insurance plan for the first 21 days of life. The Employee Retirement Income Security Act of 1974 is a federal law that sets minimum standards for employer-sponsored plans, but the employers don't necessarily need to provide newborn coverage. The Newborns Act states that insurance plans that provide maternity benefits cannot restrict someone's hospital stay, but again, it doesn't require plans to provide coverage for those hospital stays in connection with childbirth. And lastly, the COBRA states that if you or your spouse lose a job at a company with at least 20 employees, you're eligible for coverage through COBRA. So these are all of the different things that might affect your insurance policy and then the reimbursement that they provide. When talking to Dr. Roan, she provided some more details on what her NICU unit does. So she let us know that the services that they provide are mostly reimbursed via the parents' insurance policies. The insurance authorizations are handled by the department's case manager. The insurance typically pays a certain amount for the NICU stay, and this neonatal therapy charge includes all of the services the child receives, such as nursing care, respiratory care, or neonatal therapy. So as I mentioned before, the cost for families can be astronomical. Although the hospital prices are the same for all patients, they're responsible for paying different amounts depending on their insurance and payment plans. On the right is a list of all of the charges that Nationwide Children's Hospital provides on their website. And depending on your insurance, you can pay anything from $0 out of pocket all the way up to, for example, $460 for a high complexity evaluation. And these costs can quickly add up during the entire stay at the NICU. For example, the average cost of the NICU stay for babies born between 32 and 34 weeks is $31,000, and the average treatment cost for babies weighing between 501 and 750 grams is almost $90,000. Annually in the US, $10.2 billion is spent on neonatal care, and the daily costs for families can be up to almost $1,300. Across 1 week, intensive care services can cost over $18,000. There have been stories in the news of certain families that have considered filing for bankruptcy because their bills have cost over $180,000 during their NICU stay.
The American Academy of Pediatrics is in charge of the AAP NICU verification program, which reviews a neonatal care unit to make sure that it meets standards for a specific level of care. In 1976, the AAP proposed a statement to create consistent standards of service in order to improve neonatal outcomes with the goal of improving the outcome of pregnancy. In 2004, AAP created a policy of delegating NICUs to a level 1, 2, or 3. Level 1 was basic care, level 2 was specialty care, and level 3 provides subspecialty care for critically ill infants. By clearly separating the capacity and the ability of a hospital's NICU, there was hope that there would be a new standard of service. In 2012, the AAP reviewed data and they found that it supported and reinforced the creation of this tiered provision of care. In order to have a NICU, you have to go through the AAP NICU verification program process. First, the site submits a preliminary application. This application provides basic contact information and identifies the NICU's desired level of care. After they complete a pre-review questionnaire known as a PRQ, the AAP identifies surveyors with the appropriate clinical experience and without conflicts of interest. The survey team reviews the information prior to site visit. The survey team consists of an experienced and credentialed neonatologist, neonatal nurses, and pediatric surgeons who are in active practice. Surveyors are selected based on their expertise and receive training from members of a leadership team who work to ensure a high quality and consistent program. After the surveyors, the AAP survey team submits a summary report to the facility approximately 30 days following the visit. This report may then be supported to the State Department of Health. There's also many fees that can be associated with delineating the program from level 1, 2, or 3.
As medicine improves, sicker babies are living longer. Yay! But this also means that even more ethical dilemmas are happening across the country in NICUs. One research study found the greatest ethical challenges for NICU doctors was being involved in setting limits to intensive care due to a baby's incurable condition or poor prognosis. To the right, you can see some legal cases that have resulted in legal processes to aid in some of these ethical dilemmas. Some general ethical challenges across the NICU setting, as identified by the Mayo Clinic, include having a dependent patient unable to make their own decisions, the uncertain outcomes for these infants, the high likelihood that these babies will develop chronic disability, and the difficult decision families may make in light of that, and the potential trauma that can be caused by life-saving measures. One example of the last one that you might be familiar with is blindness as a result of oxygen given to babies under 28 weeks. That's actually why Stevie Wonder is blind. Liability issues within this setting in particular generally have to do with either not providing care according to standards of practice or practicing outside of one's scope of practice. A solution to the first, as we learned in 603, are clinical practice guidelines. These provide a framework for medical staff to build their care around. As for the second one, this is actually quite common in this setting because of the blurred lines between RN and MD responsibilities. An answer to that could be specialized training for each individual profession. Despite the particularly fragile nature of this setting's patients, the rates of malpractice among neonates is still relatively low. A longitudinal study over 20 years at a large children's hospital evaluated the rates of malpractice and found that though low, it did raise over the course of 20 years. And some factors with associated malpractice were increased unit growth, parent perceptions of negligence, and full-term infants with a diagnosis of neurological condition and lower parent satisfaction rates as a result of that.
Legislature and policy. To kickstart a discussion on legislature and policy within the NICU, neonatal abstinence syndrome, or NAS, is a common topic addressed. The Nurturing and Supporting Healthy Babies Act was introduced in 2016. This was a bipartisan bill introduced in both the House of Representatives and the Senate, and the goal of this bill was to expand on the knowledge of care for NAS babies and to develop an awareness of the prevalence of NAS in babies. Next, many states throughout 2018 were recorded adopting a range of different approaches to NAS. For example, in Pennsylvania, despite the growing impact of the opioid epidemic on infants, PA was the latest state to enact legislation which required hospital officials to notify Child Protective Services when children are born affected by their mother's substance abuse or are experiencing withdrawal symptoms due to prenatal drug exposure. This brought PA into full compliance with the Federal Child Abuse Prevention Act of 2003. In Tennessee, on the other hand, a statute was passed in 2014 which criminalized any use of narcotics during pregnancy. However, the mothers were allowed to provide evidence of their participation in treatment programs to act as a defense against such prosecutions. Overall, the ultimate question which arose from the varying legislation regarding NAS across states became, is the enactment of treatment or punishment by policymakers and legislatures more effective when working with expecting mothers with substance use disorder? Occupational therapists can make a difference in the lives of pregnant mothers with an addiction by assessing the person, the environment, and occupation interaction, and making suggestions on ways to implement a change in healthy habits and routines. OTs can also aid in the education process so mothers are fully aware of what NAS is and what medical complications can arise because of their current actions. The Preemie Reauthorization Act of 2018 is a renewing commitment from the federal government to prevent premature births and any associated consequences. This act was originally passed in 2006 by Congress and renewed in 2013. After the passing of this act, there was a decline in the rate of preterm births from 2006 to 2014. However, since 2014, the rate of preterm births has begun to rise again. Therefore, this new commitment provides promises on the support and the promotion of federal resources and known intervention. Next, as we all know well and dear, COVID-19 began to really affect the NICU and countless other healthcare facilities across the globe. Because NICUs are among the departments that have to take the most extreme precautions to protect the health and well-being of this vulnerable population, the pandemic quickly began to pose problems. First, OTs and all of their healthcare professionals are challenged to constantly implement and follow evidence-based practice guidelines. However, evidence-based practice guidelines and policies for the provision of care in the NICU during a pandemic were not in existence. Therefore, NICU staff and leaders were challenged with the task of finding a balance between the risks and the benefits of specific policies already in place. As a result, many policy changes were being implemented to reduce unnecessary hospital exposures. For example, many NICUs had cancellation of birth center tours, prenatal tours, and parenting classes, a reduction from multiple caregivers to only one support person, and implementation of pre-screening procedures and exposure separation policies. Within this decision-making process, a new question arose. Should parents of children in the NICU be considered essential workers? Therefore, policies and procedures in the NICU had to walk a fine line between thoughtfully developing policies with which respected and honored family values, cultures, and preferences. Overall, OTs play a vital role in this new arising question. OTs are educated to adopt a client-centered view of each client, and so therefore, OTs can be advocates within this new policy development process by recognizing the importance of family involvement and also by improving well-being and confidence among parents and enhancing management of illness. OTs can also empathize with the parents and assist them in coping with their feelings of isolation and throughout their grieving process. Finally, OTs can also provide video conferencing opportunities to foster parent-child interactions when family presence is not possible due to pandemic policies. Next, in 2020, The United Kingdom had a historic achievement by creating a law which entitled employees to neonatal leave and pay up to 12 weeks for all parents who have babies in neonatal care. In 2021, a model was enacted by the National Association of Insurance Commissioners, which included a regulation rule for double insurance plans. Because a lot of parents have their own jobs and their own insurance plans, sometimes parents expect their primary insurance to pay first and the secondary insurer to pay whatever else wasn't covered. However, this assumption caused a lot of financial problems for parents in the NICU. A term called the coordinating benefits is when parents both have insurance through jobs, so they're expected to pay to tell both insurance companies that their child's eligible for coverage under two different plans. Their birthday rule arises if the child has double health insurance eligibility. Their primary coverage plan must be the parents whose birthday comes first, and the other insurance is the secondary coverage plan. This new law is applicable for OT practice because not only should we be advocates for parents to receive quality care with proper coverage, but we also need to educate parents on insurance policies, recommend parents get in touch with their health plans before the baby's born, and encourage parents to talk to human resources at both job sites, as having a baby is a qualifying event to receive insurance coverage. When searching recent literature about the NICU, the first relevant article included a policy change for infants born at the cusp of viability, published in 2014. A baby is considered on the cusp of viability when they're born between 22 and 24 weeks gestation. After conducting a lit review, the researchers found that there's a lot of clinical scrutiny and ethical dispute around policies involving the resuscitation and treatment of this age group, as there needs to be a balance between considering an individual's best interests through ethical decision-making and any other ethically valid interest. Overall, the researchers concluded that first, a negotiation model needs to be implemented, which balances both the clinical decision-making and the parental values and opinions. The researchers also concluded that policies need to mandate individualized models for decision-making, as this is a more ethically appropriate approach than implementing a policy solely based on medical criteria. In 2018, Kennedy et al. Addressed NICU admissions after a policy to eliminate elective early-term deliveries before 39 weeks gestation was implemented. The hypothesis of this study was that if a policy were implemented which eliminated elective early-term deliveries, this would result in fewer NICU admissions and shorter lengths of stay among infants born at or before 37 weeks. To explore this research question, a retrospective cohort study was implemented, comparing the incidence of early-term deliveries, NICU admissions, NICU diagnosis, and stillbirths before and after the policy change in 2009. Overall, the implications for OTs for both articles involving policy changes is that OTs need to be advocates for client-centered care through a negotiation model which provides a balance between parental values and clinician decision-making skills. OTs also need to stay current in the literature and continually implement evidence-based practice. Additional advocacy opportunities include encouraging questions so family members develop a continual awareness of the NICU experience, advocating for additional skin-to-skin care and for parents to sleep at the bedside of their infants, mentorship and individual support groups so current NICU families can contact previous NICU families. In addition, we want to advocate for positive infant experiences in the NICU environment, affordable costs and awareness of current policies, and overall advocacy for continual and further OT involvement.
NICU babies are at higher risk for developing neuromuscular disabilities such as cerebral palsy. You might remember from Health and Health that two injuries are associated with developing CP: HIE, hypoxic ischemic encephalopathy, and PVL, periventricular leukomalacia. There currently exists one highly innovative and highly effective treatment for HIE, total body cooling, but nothing exists for babies with PVL. Hopefully more research will be done in the future around this population, and OTs can certainly play a role. Though family-centered care has always been important, recent research shows that the needs of siblings are often neglected. And though parental presence has garnered them the ability to be at bedside 24/7, at least at Jefferson's NICU, parents are still not allowed to sleep beside their baby. This needs to change. Finally, infants with neonatal abstinence syndrome present an additional need within the setting, as these babies are going through withdrawal and often don't have the supportive family. OTs have already begun developing programs to support this vulnerable population through infant massage, staff baby wearing, and volunteer rocking programs. As you can see, OTs play a vital role within this setting. The role OTs need to take to address these gaps of care is the role of an advocate, and they will need hospital support in order to develop programming to best fit these gaps. Looking specifically at gaps seen within family-centered care, OTs should advocate. They should advocate for sibling needs by developing sibling support and play groups for siblings to have a space to process their feelings around having a baby sibling who is very sick. This would be a safe space where siblings can process with others who understand through the facilitation of occupational therapists. OTs also need to advocate for parents. Parents should have the right to sleep at their baby's bedside, and this is something that they would be able to do if their baby was not sick. Another area where OTs really can make a difference for these families is by providing family peer mentoring. Peer mentoring is not a new concept within hospital settings and is commonly used with adults with SCI. By preparing these families for the future and by showing them what a vibrant, joyful life their babies can lead one day, even if they're given a disability diagnosis, these families will find hope and joy, even in the midst of a diagnosis that they were not expecting.
So here's a list of our references that we used during our PowerPoint. And here's just a big thank you for joining us to learn about the NICU. If anyone has any questions, don't hesitate to reach out.